Mullen, Senior Manager from Manat Health. On this slide is a full list of organizations and their representatives participating in this work group. As a reminder, we have posted a list of all the representatives and their biographies on the CDA website. A member of our team will drop that link in the chat shortly. We have included workgroup member bios that were submitted to CDA in the document that you will see. At this time, I'd like to invite representatives from these organizations who are here for today's meeting to introduce themselves in the chat. Please drop us a little note letting us know that you are here. Give us your name, your title, and the organization that you are representing today. Great, thank you. While folks are saying hello and getting warmed up, there we go. I'm going to talk about the work group's task. So before we review the scope and plan for work group meetings, let's take a minute to remind ourselves of what it is that we are tasked to do. This work group is tasked with bringing together diverse perspectives from across the state and building on learnings from the COVID-19 public health emergency. The LTCFA work group will develop recommendations for access and visitation policies for future states of emergency. Next slide, please. As a reminder, this work group continues to evaluate the impact of restricted access on the mental health of residents, families, and friends, and on the physical health and safety of residents. To recap, the long-term care facility access work group will engage in a total of 4 meetings, and they will build on each other. In the last meeting, the work group discussed key elements that the work group's recommendations should contain. We call these key elements actionable principles on which the work group's recommendations will be founded. Since the last meeting, the group provided written feedback on the draft set of principles, which we will discuss today. Most of today's meeting, as well as meeting 4, will be dedicated to identifying specific policy and practice recommendations for future emergencies based on the actionable principles. This slide outlines the plan for today. Today, we will identify policy and practice recommendations for future emergencies. We will summarize the work. We will provide a summary of submitted work group feedback on draft principles and develop policy and practice recommendations that establish the following: a process for residents to designate visitors, standards for safety protocols, visiting parameters, and compassionate care visits, and a process for establishing any protocols and parameters to address situations where standards may not apply. And with that, I will turn it over to Mark Beckley.
My name is Mark Beckley. I am the Chief Deputy Director for the California Department of Aging. I will be walking you through the work group feedback that we received on the visitation principles that were sent out via survey to all of you. But before I do that walkthrough, I'd really like to thank all the residents, family members, State Department representatives, advocates, stakeholders that have participated in the work groups and provided your feedback, your input, your personal experiences and insights into the work of this work group. Your participation, your input has been invaluable, and I'm just really happy to see the high level of engagement that's occurred within the meetings, but also that we saw through the survey feedback. We had approximately 19 stakeholders respond to the survey, which is close to the majority of our work group. So thank you so much for those of you who did complete the survey. Your input was so needed and so valuable. And I also really want to emphasize again, Brandy had stated this is the last of two, or the second of two meetings that we have left. So please, as you listen to the discussion today, participate on those points that you're strongly in favor of. So those principles where you really want to emphasize and you think are really critical to support, as well as those areas of concern. And I kind of reach out to our advocates as well as our public health partners. If there's something you're not comfortable with, if there's a wording change, if there's a tweak or a provision you want to make for those principles, please speak up and speak up now, because this time is valuable. Only 2 work group meetings left. And it's really our charge to come up with principles and perspectives and recommendations that we can then submit and report to the legislature. And even if we see a great sort of like consensus majority support for certain principles, we also want to, capture any dissenting opinions or views in our report as well. So please do actively participate and speak up. It's really important. So going into the principles themselves, what I want to start off with is really talking about the process that MNAT and CDA used to develop the principles. So what we did is we went through the previous meeting transcripts, comments that were submitted, questions that were asked from the work group members and from the members of the public in order to formulate these principles. In all, we've captured 7 actionable principles that are related to long-term care facility access and visitation. And we developed these into areas of alignment from the work group members. These draft principles were then sent, as I mentioned, through a survey to work group members for their feedback. And what we were looking for is we did provide some open field comments where you could provide feedback, ask questions. But by and large, the questions really asked you to rank your agreement and alignment with the principles on a scale of 1 to 5. 1 being where you disagree and felt you could not support a principle, to 5 where you are in complete agreement with the principle. We also provided an option of 3 where you might have just been neutral. We reviewed all the input that was provided on the survey and really summarize that survey and that feedback on the slides that you're about to see. In general, I'll say that there was really strong agreement and alignment with the principles, and you'll see that at least from the work group members that responded to the survey. So it's nice to see that there is general alignment and agreement with the principles that were defined. In the discussion today, we have provided some edits to the principles based on feedback that we received from the work group members through the survey. We're going to walk through the feedback and the edits pretty briefly today. We only have 2.5 hours for this work group meeting, and we really want to reserve the majority of the time from hearing from you. So I'm just going to give sort of like a broad overview of the principles. But I do want to acknowledge that based on the feedback that we hear from you today, that we will continue to refine these principles and send them back to the work group for further review. So slide 18, or next slide. I'm not going to read the entirety of the principles, but I do want to highlight the main components of the first principles, which is that long-term care facility visitors are essential to a long-term care residents' well-being, and that the work group members do think that they should be considered to be a critical component of a resident's care. We kind of entertained the idea of saying that they're a critical portion of the resident's care team, but we really didn't want to confuse that with the care teams within facilities that are comprised of professional staff. So we just said that they're a critical component of a resident's care. So as you can see from this slide, there was overwhelming agreement on this principle. And like I said, we'll continue to refine the language. And I believe that this principle actually had the greatest number of respondents. Okay, moving on to the next slide. So these are actionable principles 2 and 3. And again, as you can see from the histogram results, there was very strong agreement on both of these principles. I'll paraphrase principle 2, which recommends that California establish a framework that gives long-term care facilities clear standards on how to enable visitation during a state of emergency. Principle 3 basically articulates that proposed framework would include residents' access to timely appeals and a grievance process to address situations where visitation standards were not adhered to. So if a visitor was denied and they felt that they were denied unfairly, this grievance process would be available to them. I think the comments also emphasize that in developing these standards and this appeals and grievance process, that it's very critical to involve public health offices, our state long-term care ombudsman, long-term care facilities, as well as licensing agencies. Next slide. So principles 4 and 5, and again, as you can see, strong agreement and alignment with both of these principles. Principle 4 states that proposed framework would establish that residents could see a wide range of visitors during a state of emergency, subject to any parameters that were set forth in principles 5 and 7, which we'll discuss in a moment. I'll flag a language modification that was made to this principle. We've been kind of using the word right, and I think it's really important to put the term right in proper context. So right, in terms of how we're defining this work group to date, really is that residents should have the ability to have visitors and visitations even during a state of emergency. What we really want to distinguish this from is a legal definition of right. That is something that is, say, set in statute or set in a constitution. And so we're not using a legal definition of the term right. However, if any work group members feel strongly that there should be something that's codified as a formal right for residents, that can certainly be, put forward as a recommendation. But in terms of this work group, we're not going to attempt to create a legal definition of right. We just don't think that we've got, the right people or the expertise to really go down that path. But that is something that the legislature could absolutely entertain. In principle 5, we saw alignment for the work group for these recommendations that visitors must adhere to the same safety protocols as long-term care facility staff, although acknowledging that external factors such as, but not limited to, supply issues could contribute to some variation. And of course, we saw that during the COVID pandemic where, the general public did not have access to things like PPE or vaccination, maybe as quickly as long-term care facility staff did. And then in this survey, we saw feedback and questions that we'll spend more time talking about later today in this presentation. Okay, next slide. So actionable principle 5B. This principle has been adjusted slightly based on work group member feedback that voiced concern that one, not including residents and families directly in this process, and 2, permitting different safety protocols as a result of staffing levels. The proposed principle has been revised to specifically call out the inclusion of residents and family representatives to work alongside public health officers, long-term care facility operators, resident advocates to collaborate on safety protocols for long-term care facilities visitors during a state of emergency. In the detailed recommendations that support this principle, the work group may want to define which and how external factors may impact safety protocols for residents. Okay, next slide. Okay, principles 6A and 7. So here, work group members, again, we're in clear alignment with both principles 6A and 7. 6A states that visitation parameters to account for operational and safety considerations, such as, but not limited to, hours of visitation and number of simultaneous visitors, must not reasonably inhibit a resident's ability to receive a wide range of visitors and must be transparently communicated to the public. I think this is something that, we've heard from residents and family members that there was pretty significant variance among facilities in terms of either visitation hours or the number of visitors that could be entertained in a facility at a given time. Principle 7 states that when compassionate care is needed and acknowledged, the importance of visitors during these moments of crisis, the proposed framework would provide guidance to long-term care facilities on enhanced steps to mitigate operational and safety considerations and enable timely access to visitors. So what this really speaks to is if there are issues such as supply chain issues that facilities should, to the extent possible, extend accommodations such as if they have excess PPE, for instance, that could be extended to compassionate care visitors, they should do so. And, we might also look at, like in a public health emergency, if there's an ability for compassionate care visitors to receive vaccinations, say, in a higher priority. And again, we saw feedback and questions about the details behind these principles. And again, that will be the purpose of today's discussion, is to delve deeper into your questions and concerns and also further refine and define these principles. Okay, next slide. So slide 23, this speaks to actionable principle 6B. This is the last principle we will review. This is similar to principle 5B. This principle has been revised again based on work group member feedback that voiced a concern with A, not including residents and families directly in the process, and B, not having a period of time where resident designated support persons are not able to access the resident. Taking these concerns into consideration, a proposed edit has been proposed to, again, directly include resident and family members among the parties that would work with public health officers, facility operators, and resident advocates to collaborate on parameters that would enable visitation. And again, we'll talk about the feedback that we received from work group members as part of the survey process and our discussions. All right, next slide. And then, finally, I just want to acknowledge that there was additional feedback that was provided from work group members on all these principles. I won't read through this chart, but I do encourage you, if you haven't been able to do so already, to review the comments. We really appreciate the comments that we received and the time that people took and the thought that they put into producing these comments. We're really going to, and we have, to the extent that we could, use a lot of your comments to help refine the language of the principles or the content of the principles. And again, during today's work group discussion, please speak up. If there's something that you haven't thought about yet, that you haven't captured through the survey process, we really want to hear your comments verbally in the discussion today. And with that, I'm going to turn it over to Juliet.
Wonderful. Thank you, Mark. So with that, we are looking forward to transitioning into a conversation about policy and practice recommendations. I'm going to walk through some framing first. We do find that I know we've been doing quite a bit of framing at the top of this call today, but it's helpful to get a kind of sense of the overall arc of what we're going to talk about so that we can then focus in specific areas, because I think, we found in past conversations, it can be hard to talk about one isolated element of these recommendations without having the broader context of what they all look like. So if we go to the next slide, please. So the focus of today's conversation is really going to be developing this recommended framework that Mark just spoke to, and really using principles 4 through 7 to develop that framework. And so we're really going to be focused there today. I saw a lot of comments in the chat about, things we need to add more definition to. What do we mean by compassionate care? What do we mean by timely? That is the entire focus of today's conversation. I will flag there is a very important principle around the appeals and grievance process that we want to spend a lot of time on in this work group. We are proposing having that be the focus of meeting number 4, our next meeting. So today, what we're going to do is we're really going to focus on defining and workshopping as a group some recommendations around what the framework looks like at a baseline. And then in our next meeting, we'll focus much more on the process around appeals and grievances for residents and loved ones when things might not be working the way that the framework is recommending that they need to work. So if we go to the next slide. So the conversation today is going to be split into 3 parts. We're going to start first by discussing a recommendation for the process for residents designating visitors. So this is really getting to the who can be a visitor in this framework. The second component here is we're going to look at those standards that we alluded to in the principles. So in the principles, this work group gave a lot of great feedback and aligned around this concept of establishing some standards so that it's not completely variable from long-term care facility to long-term care facility, and it's not open to interpretation what the baseline standards should be. So we'll talk about standards, and that'll be in 3 parts. We'll have a conversation about standards related to safety protocols, standards related to visiting parameters, and then standards relating to compassionate care specifically. And then our last section for today is going to be recommendations on process for developing any protocols or parameters in situations where standards may not apply. So that's that 5A and 6A scenarios. We'll build those out into actual recommendations. Next slide, please. So I want to caveat, I know folks just got these materials not that long ago and are probably just beginning to digest all of it and thinking through positions and ideas for this. What this deck recommends and what this deck represents and the following draft recommendations are is that these are really developed based on those actionable principles and based on feedback and discussion of those principles. So as with the actionable principles, we really went back and looked at the totality of the workgroup conversations to date, all of the written comments and chat comments submitted, all of the research, and put together straw man recommendations for us to begin to workshop together. These are by no means final, and the intent is to really talk them through today and to workshop them. So next slide. So we're going to, as I noted, it'll be in 3 parts, our conversation. I'm just going to talk about the high level elements of the framework, and then we're going to dive in. So the first element around a process for designating visitors at a high level, the straw man recommendation here outlines that in a state of emergency, a long-term care facility resident or their designated decision maker, if they are unable to decide for themselves, can designate any individual as a resident designated visitor who has access to the facility for in-person visits subject to the protocols and parameters in this framework. So we're really going to spend some time defining the designation process, and we're going to spend about 30 minutes there. Next slide. Once we are done with that conversation, our longest section of today is going to be standards for visitation. This will be in 3 core parts. And I'm just going to go through at a very high level what the recommendations are, and just note that we're going to talk about all of the definitions and specifics in a moment. So the first piece is around safety protocols. And the straw model that we'll be discussing today starts from a baseline of saying, as a standard during a state of emergency, facilities may not impose different protocols for staff and visitors. So we'll do a lot more definition there. The second piece is saying, as a standard during a state of emergency, visiting parameters must reasonably allow resident designated visitors to conduct in-person visits with the resident and must at least meet minimum standards for number of permitted simultaneous visitors, visiting hours, and locations of visitation. So as people are commenting in the chat, the definitions behind all of those are going to matter a lot, and so we'll talk about that. And then the third section of this part of the conversation is going to be about compassionate care. And so we'll be looking at, in particular, scenarios of compassionate care as a standard during a state of emergency. We'll start from a baseline recommendation to workshop that visiting parameters, including the number of simultaneous visitors, visiting hours, and locations of visitations, should be expanded to enable compassionate care. We will define compassionate care, and then we will define minimum standards. Next slide, please. And our final section is going to be defining that process that we spoke to around what happens when standards may not apply. And so we will talk about a process through which various stakeholders will be brought together to establish protocols in situations where the standards may not be able to apply. When it comes to safety protocols, we'll start from a baseline recommendation to workshop that says, in situations where visitors may need to follow unique safety protocols to account for external factors such as, but not limited to, supply issues for an extended period of time, safety protocols for visitors must be determined at the county, city, or state level, not the facility level. And so we'll talk about, well, what is an extended period of time? What does that mean? And we'll talk about the definition of the actual process for defining protocols. And then we'll do the same thing for visitation parameters that are not safety protocols. I've just talked a lot. I'm looking forward to getting into the discussion now. Let's go to the next slide. So section 1, we are going to talk about the process for designating a visitor. Our goal here is to not spend more than 30 minutes in this section, and you're actually going to see these time cues throughout. What we're going to do to leverage really the strength and the power of this group's expertise and advocacy is we're going to time box some of these conversations and then leverage a polling tool to be able to gauge alignment and keep moving the conversation, because as you've just seen, we're trying to get through a lot today. Next slide. So in scope for this conversation is how individuals are selected to be long-term care facility visitors and which individuals can be selected. We're not yet going to talk about safety protocols or visiting parameters. That'll be in the next section. Next slide. All right, we get to our first straw model recommendation. So acknowledging that I know folks are probably still digesting some of the materials, I actually will take a moment to kind of walk through this. And then we're just going to open it up to 15 minutes of conversation. Once we get to the 15-minute mark, we're going to invite people to give an indication of their level of support for this recommendation. And then we'll continue some conversation if the work group feels like there needs to be a lot more workshopping here. So I'm going to read through this and just again acknowledge this is a starting point. We're looking for people to react. It's a lot. We think it'll be a lot more helpful. It'll be really helpful to have something to base this off of. So I'll just read a couple points of this, and then I see we already have some hands raised. The core top line item here is that in a state of emergency, the work group recommends that a long-term care facility resident can designate any individual as a resident designated visitor who has access to the facility for in-person visits subject to the safety protocols and visiting parameters in this framework. So we're not going to talk about those safety and protocols and visiting parameters just yet, but we are acknowledging that that's a note here. We are going to have a long conversation about those in a moment, though. Here we indicate who resident designated visitors may include, but we do note that it's not limited to that, and certainly welcome input and additions and edits to this list. We do note that if a resident is unable to speak for themselves, that there would be a process for ensuring that a resident designated visitor can be named, or multiple resident designated visitors can be named. And then we note here at the bottom that as a standard, facilities may not limit the number of individuals who may be designated as resident designated visitors, but they may require visitors to follow safety protocols as a condition of in-person access. And visitation may be subject to operational and safety parameters, such as a limitation on the number of simultaneous visitors. So I see we already have a couple hands raised, and I'm just going to go straight there. So the first in line, we have Karen.
Hi, thanks, Juliet. So 2 points. One on the first bullet point is ombudsman probably shouldn't be included there. We have our own access to facilities, and the residents don't need to designate us. And we wouldn't want to be in the way of a family or other visitor for them. And then the second bullet point of if the resident isn't able to speak for them, then certain people could designate for them. I think I speak for a lot of ombudsmen that that can be a real nightmare when the designated person doesn't get along with other family member. They might leave out people that the resident would otherwise want. And in California in particular, really the healthcare agent isn't able to make visitor decisions. The only people who can is the resident, or if a judge gives visitation control powers to a conservator of the person. And that's even documented in court records. It's documented in court forms. I don't know how to solve this for those residents, except maybe a grievance procedure can be added so that if somebody isn't designated, they would be able to find out they haven't been designated and then have a way of grieving it. You know, where would they go to figure out who could kind of resolve that so they can get added to the list when, you know, maybe it's one sister who doesn't like the other sister and won't let her be the designated person, even though mom or dad or whoever might have always wanted them present. So that probably needs more fleshing out, and it's going to take a little bit of work.
Yep. So, and that would kind of look like a process where rather than there being a process to make sure, you know, everyone has a resident designated visitor, it's more about making sure that individuals who are raising their hand and saying, we want to be a resident designated visitor, we think we should be a resident designated visitor for this person, and there's no process, what do we do? Like having a process for that. Okay.
Right. Thank you.
Thank you. And I think next we have, oh, it is long-term care facility policy workgroup panelists. It's someone that didn't update their name. Looking at the icon.
Hi there.
LTCO?
Can you hear me okay?
Yes, we can hear you.
Hi, this is Jason Sullivan-Halpern from the Long-Term Care Ombudsman Association. Just following up on what Karen said there, definitely agree with those recommendations. And I would just add to that I think ombudsmen and like state survey staff would be on sort of the same level. Like it doesn't make sense to me that a facility would be able to use a state of emergency as a way to turn away regulators or something if they were needing to access the facility for monitoring. And I think ombudsmen fall into that sort of category too, because we, the ombudsman, you know, have some state authority to access visitor residents whenever they want, really. So I think there should be like a special category for that, because I definitely agree with Karen that by framing it as like the resident needs to designate these visitors, I think there's definitely some visitors they don't need to designate. Thank you.
Thank you, that's helpful. So that might look like saying there's resident designated visitors, this is what that process looks like for designating them. And then there's other types of visitors, ombudsmen, state surveyors, that may be subject to the same parameters and safety protocols listed here, but are not resident designated. That's really helpful.
Yeah, I would add law enforcement, exactly.
Got it. Great. All right. Next, I see Catherine.
Hello, everyone. Thank you. Just one small clarifying question in the bolded A. It says any individual, which might be viewed by some as singular, and I don't think that's what is intended. So maybe adding an S in parentheses after that, so it's clear throughout, because you use visitors plural in other places. But I actually wanted to speak to the second bullet. That individuals unable to speak for themselves, California has a supported decision-making statute that allows someone to help that person figure out what they might want to say. And I think that's an important concept to weave into this discussion. I think saying things like the resident is unable to speak for themselves, I think that's actually not a very clear legal standard of what does that mean, right? So I feel like it's our collective job to help people, like even people who lack capacity to make a medical decision, I believe in many cases will have an opinion about who do they want to see. And the question really would be, how do we help them articulate who they want to have as on their list of visitors, right? So I'm not suggesting we go to a legal standard. I just think that requires, as others have said, some additional work. Thank you.
Thank you, Catherine. Appreciate that. And I think we're seeing a couple comments to that effect as well in the chat. So we will, I think I'm hearing a general agreement that there needs to be a way to ensure that someone who might, again, acknowledging that that's not a particularly legally enforceable statement, cannot speak for themselves. There needs to be some way to support them in making sure they can have visitors. That may be a combination of supporting people who are raising their hand and saying, I would like to be a visitor of this person, and having a process for them, as well as a process, as you just noted, Catherine, to support the kind of help support residents in identifying members if it's something they need help with doing. So we're tracking both of those pieces around that clause, and we can do more workshopping there. Let me go back to, oh, I keep losing. So sorry, 1 second. Coming back to my list. Melody, you're next to my list.
Hi. Hi. And this may have been talked about or alluded to before, so I'm sorry for any duplication of comment. But in the first bullet point where it's talking about resident designated visitors, but then it goes on to include a list that the resident may, like they may not designate a healthcare worker, an outside healthcare practitioner, et cetera, that's on the list. And as I'm also looking at some of the other language that says wide range of visitors, just wanting to make sure that the language is stated such we're not backing ourselves into a corner of resident designated visitor. And, you know, you have an outside healthcare practitioner coming in, but they're not on the resident designated visitor list. So perhaps there needs to be some language that's a distinction between the resident designated visitors and those who I think Karen and some of the other ombudsmen talked about it before, you know, we should just, you know, have access as well without necessarily having a specific designation by the resident. That makes sense?
Yeah, that makes sense. Thank you, Melody. Tracking that. Next we have Ellen.
Yes, hi. I just have a couple comments. One of them is that I think the resident, we should state somehow that they can designate ongoing. They may designate somebody today, tomorrow they designate someone else. It's got to be a fluid process, not a one-time process. So I'm not sure that's completely clear. The other comment, and I don't have an answer to it, is just how many people. I think that is a real challenge during an emergency, is how many people are on site at a particular facility.
Yep.
So in some way, shape, or form, figure out how to discuss the number of people that can come at any given time.
Yeah, absolutely. I appreciate that comment, Ellen. I think in a couple slides, once we kind of align on this piece, we'll talk about, you know, so you maybe have 5 family members. What does it look like at any given point in time in the facility, and what is a standard for simultaneous visitation? Yeah, it's a great call. Thank you. Tony.
Hi, good afternoon. Thanks for putting all this together. Really appreciate it. Sort of in this vein of how language is so important, a couple things. I know we may be using the term state of emergency as sort of shorthand for a larger process where visitation rights are specifically disrupted, but I think, and maybe it was addressed in a prior slide, but I think at some point there should be a discussion of what we mean by state of emergency, because just a general declaration of state of emergency wouldn't impact nursing home visitation or long-term care facility visitation. Normally, it would require a specific inclusion of a limitation of visitation, an extraordinary kind of specificity. So I don't want people to get the wrong idea that any state of emergency, we can suddenly, we have things that happen with visitation that wouldn't normally happen. Another thing is the term visitor. And with AB 2546, we were very deliberate to not use the term visitor, and so we use support person, because we felt visitor sort of minimized what the support people bring to the table. So that's a word that I'm having a little trouble with using. I get it, and we want to be broad here, but visitation, I think, minimizes what we're getting at. And then the third thing and last thing, I promise, that I want to talk about on this slide is the in the bullet points, the term designated decision maker. A lot of residents, I think the majority of residents probably who have decision makers who aren't making their own decisions, don't have a designated decision maker. They haven't done a healthcare directive or a designation, an oral designation of a surrogate through the probate code process. It's usually a default kind of thing. A family member steps up, they haven't been designated, they just sort of take the reins. And now there's a new default surrogacy process under state law, went into effect on January 1. So I'm a little worried about the term designated when you're talking decision maker.
Yep.
We usually uses the term, resident representative, and even though it's not very well defined legally, it's, I think, more inclusive to the reality of how surrogate decision making happens in these facilities.
Yep. Tracking that. Thank you, Tony. All right, I see Eric.
Yeah, I can just go follow up on what Tony just said, agreeing that designated decision maker doesn't mean anything, or may suggest too much, because there is no such thing. And it's a problem, right? This I'm sure everyone on this call knows the difficulty here. Just like Tony said, most people don't have formal, there's not someone with formal legal authority, and in practice, the system runs to a certain extent well, or sometimes not so well, on some informal understandings of who's going to step up, and oftentimes there's just some implicit understanding that someone's adult child, for example, is going to participate. So there just needs to be some clarity there. And maybe I'm not, I don't necessarily want to be held to this, because we're still obviously thinking these things through, but maybe there could be some acceptance of some informality, because trying to come up with a formal designee, and even the bullet point right below that, convening the ombudsman and the other stakeholders, that's a lot of process and a lot of time and a lot of difficulty. And I can imagine in these situations, it might get in the way of allowing someone to visit. So there's some significant issues there, and it may be that, again, I'm not sure I want to be held to it, but maybe there should be less process rather than more, and some acceptance of some informal understandings, as opposed to nailing everything down with maybe undue process, because we're talking about allowing someone to walk in the front door and say hi. We're not giving someone's authority to make medical decisions,
right,
or to make financial decisions. It's the risk is less there, and there maybe should be less process because of that.
Thank you, Eric. I think that's really helpful. I'm going to summarize kind of the core elements of feedback that I'm hearing and how we may want to continue to workshop this. And then we're actually just going to pause and we're going to ask people to kind of tell us their level of agreement with being able to kind of move forward with this general concept, understanding that we're going to continue to evolve it based on the feedback that we got. But I'll just summarize my core takeaways here. So I'm hearing a lot of feedback on this concept of what is included within a resident designated visitor and looking at specifically kind of actually having different categories around a resident designated visitor versus state and long-term care ombudsman, state surveyors, that kind of category of individual that would have access to the facility that's not employed by the facility. And then another category around healthcare providers, service providers that are not employed by the facility and their access, and acknowledging those are distinct categories that are not necessarily resident designated visitors. So that's one area of feedback I'm hearing and an area for us to workshop a little bit more. I'm going to recommend, after the meeting, we'll do a little bit more iterating, and what we'll share at the end of the conversation today is we're going to do multiple rounds of iterating on these and getting more feedback from you all based on the conversation today. So we'll take that note and that comment and look to incorporate that. And then I'm also hearing a lot of feedback around this process, what it looks like, that middle section, and kind of thinking through how we ensure that people have access to a visitor without developing too much process here that may be unclear or onerous. That's one element that I'm hearing. I'm also hearing the recommendation kind of at the top of this section that there may be a way to actually build this element in or ensure some of this through the appeals and grievance approach, rather than necessarily building out a whole process that we have to have for designation in these situations. So those are kind of two major areas I'm hearing. We'll kind of go back through the transcript after the call and workshop this a little bit further based on those two major areas of feedback. With that, I'm going to take us to the next slide. So we're going to try to use technology. And I'd say try because I feel like it never quite works how you need it to work when you most need it to work. But we have a poll everywhere tool. Folks who are members of the work group should have received a link that you can access at this time. And I'm also going to ask, thank you. One of my colleagues just dropped that link in the chat for work group members. I'm going to ask members of the work group to go ahead and go into that survey and indicate kind of based on where we are, based on the recommendation we looked at and the two areas we just aligned on workshopping a little bit further. What's your level of comfort and your level of support with where we're landing around this first recommendation? And so exactly like in the survey that you all did, we're asking you to say between a 1 and 5, how you're feeling about this, or where you stand rather right now on this recommendation. 1 is I disagree and cannot support. 5 is I completely agree. I do just want to acknowledge this is not a vote of the work group. We're going to continue to workshop. This is a facilitation tool to see if we're comfortable with where we're landing right now and can move on to the next section. So with that, I think on our next slide, we'll be able to see how people are voting. Okay. Oh, yes, and someone just noted in the chat, I'm also tracking that area to workshop, which is being a little bit more crisp when we say state of emergency, about it being a state of emergency that impacts visitation and developing some more language there. Okay. I'm seeing some general alignment, acknowledging that we do have a 2 and a 3. So what I will say is I think we've got enough to kind of keep moving into the next section, acknowledging we're going to send this back around for another round of iteration and feedback for the group. We will move into the next section. Before we move into the next section, I do want to pause, and before we start talking about standards for visitation, I do want to open to members of the public that have joined today. We just got a pulse check on where our work group members are, and are gauging that they're comfortable moving into the next section, acknowledging we're going to keep workshopping a little bit more, but moving into the next section. If there are members of the public who would like to give any comments around the recommendation we just looked at this time, we're going to open that up. So I've got my eye on the list to just see if we have any hands raised. And Teresa, I see you have your hand raised. And I'm going to ask the oh, actually, I can do it. So Teresa, you should be able to unmute yourself.
Can you hear me now?
Yes, we can hear you.
Yeah, I think it's really, really important that any limitation on the designation of the visitors, the number of visits, the number of people that can visit and the time they can visit be highly individualized and not arbitrary. And this is one of the things we saw where there were just sort of arbitrary limitations that it has to be, each decision about that has to be individualized to the resident. And it cannot be left to the industry or the nursing home administration, who will act for their own convenience, as we saw during the pandemic. Thank you.
Thank you, Teresa. Appreciate that comment. All right. I think with that, we can move into the next section. So we've just talked about a kind of baseline that we're beginning with, that residents can designate anyone to visit them. But we also acknowledge that, you know, in order to have in-person access to the facility, the visitor would agree and would have to adhere to safety protocols. So we're going to talk about those safety protocols. And then we're going to talk about parameters in terms of the number of visitors and the time of visitation and elements like that. But let's start with safety protocols. So if we could go to the next slide. So here we're going to focus first on safety protocols. Next slide. And I want to acknowledge that we're talking here about the standard. We will talk a little bit later about what happens in a situation we can't anticipate. So if we're acknowledging that we can't predict everything into the future. And so we will talk after we're done, like setting an essential set of standards for this. We will talk afterwards about the process if standards may not be able to apply and what happens and how are those developed. So just want to acknowledge that before we talk about standards. So this first recommendation is about safety protocols. At a high level, it states that as a standard during a state of emergency, the work group recommends that facilities may not impose different safety protocols for staff and resident designated visitors. Safety protocols include conditions for an individual to enter the facility, which may include requirements for testing, vaccination, isolation, quarantine, personal protective equipment, or others. This list is not intended to be all-encompassing, it's intended to be illustrative. And we are acknowledging that there may be situations in which external factors to the facility may create variation between the safety protocols that may reasonably be allowed by staff versus residents. So an example, for example, that I'll just suggest and put out there is one, for example, that happened in COVID, where vaccines were rolled out in waves. And so staff in the facility may have had access to vaccination prior to visitors. This is acknowledging that there may be situations like that where access is a little bit different, and that may just impact the ability to follow the same protocols. What we're acknowledging here is that if a situation like that persists for an extended period of time, which we are setting kind of an initial proposal that extended period of time is more than 30 days, counties, cities, or the state should follow the process recommendation established in recommendation C for establishing visitor-specific safety protocols that allow resident designated visitors to visit residents. We're going to talk about that process a little bit later, but we just want to acknowledge that if there's ever a situation where, for whatever reason, the ability to follow a safety protocol looks different for staff or residents, if that persists for more than 30 days, then we're going to this process of establishing protocols with a number of different stakeholders, and we'll talk about what that looks like. I'm going to pause here and take comments and questions. And Maitli, I see you've raised your hand.
Hi. Yes. In regard to situations like that, in relation to the specific example you gave, vaccines. So in our experience, at least in my experience, a lot of the staff members, there were very few staff members because a lot of people had quit, passed on due to the virus, or they were afraid to get the vaccine. So they were not getting them in the numbers that we wanted.
Mhm.
And so family members were invited, sort of proactively in case we could get in. And I was getting in, so I immediately signed up, and my husband as well, so that, we could be a team. And I just think that's going to happen again. Like if we're in a situation where we're the support people, my mom can't wait 30 days for support. She would not have anyone feeding her or giving her beverages. She's full support, right? And when staff was minimized, she didn't have anyone coming into her room. They just did not. They put food outside. She's quadriplegic. So I'm just saying that I agree with the statement that this has to be highly person-centered. And also these sorts of resources should be used for the family support people, because they are literally filling in for staff. Not that we want to be unpaid caregivers, but when an emergency strikes and we are needed, we are at the door ready to go. So I just wanted to make sure that's clear and referenced and considered, please. Thank you.
And so can I just ask a follow-up to you on that? Would that maybe look like adding an element around recommendations about like prioritization and investments related to supplies and things like that?
Yeah, I see that definitely being necessary for people who are coming in and providing support.
Great, thank you.
Thank you.
And I keep moving away from my list here. Eric.
Thanks. I want to comment on the last bullet point here. I think there's some ambiguity in how it's written currently. It seems like a statement of fact. Residents may not have access to PPE at the same levels as staff. And I assume it's meant to be a statement of what should happen. There's a further ambiguity because I guess it's implicit here that the facility would supply PPE. Is that the understanding? Or I think it needs to be clear, because that's obviously, I think a lot of what we're thinking about it, access in the COVID context relates to PPE and to the discussion of restricted access. So I think there needs to be some clarity here. If it's the intent to state that the facility has to require that for people, under whatever circumstances, then I think it should be explicit here. And it should be clear what the priority is, because I think that last bullet point doesn't do it. It raises the issue, but it's not clear as to how that's supposed to play out.
Yeah, I will just say there was not an intention around the recommendation for whether a facility would provide or pay for PPE, because we didn't, going through all the transcripts and what was shared in the past, we didn't gather that from past work group conversations, but welcome your thoughts on that.
Well, I mean, as a practical matter, that's a lot to require from somebody's daughter or next door neighbor, that they come in equipped the same way a healthcare worker would be equipped. It's too easy, I can imagine, for the facility just to say, "Oh, sorry, you don't have it right.
Yeah.
You can't come in. So again, so much of this conversation is based on a COVID type of scenario, because that's what we're coming out of. But you can see how that would play out if the expectation is that people would have to provide it themselves, and that they would have to meet the facility's standards upon entering the front door of the facility. You can imagine a tremendous percentage of people being turned away.
Thank you, Eric. I see Melody is next with her hands raised.
Hi. Just kind of wanted to interject this thought. It might be a little bit premature to another segment of the conversation, but regarding PPE, and one of the things that, is saying, hey, caregivers, we want to get in we'll use the same PPE as staff. And I'm not sure how this can be worded or expressed and so forth. But I just wanted to put an example out there of a situation that I ran into where I was required to use the same PPE or PPE that was required by the healthcare facility. And I think it created a little bit of a conundrum for me. One of my chosen family members was in the hospital for about a week. And on a side note, I was only allowed to visit her at the nursing home for 30 minutes, 1 day per week, but I was able to visit her at the hospital every single day. However, regarding the PPE, I have to park my car, took out a brand new, high quality N95 mask. And I walked into the entrance of the hospital and staff said, you have to throw that out. And because of the standards that were in place, I had to throw out this really good, safe, high quality N95 and replaced it with a mask that I could get at the dollar store. So I think while there was, part of, using the same PPE as staff, that this was also a situation where it was detrimental and not as effective. Not quite sure how this would frame all in there, but just wanted to put that thought out. So.
Thank you, Melody. Appreciate that. Jack, so you have your hand raised.
Yeah, no, I'll just be really brief. I just wanted to echo the comment. I almost felt I was beat to the punch there on that second bullet. I think just there is something implied there that the facility is required to provide the PPE or whatever else may be needed. So I think that is a good point of clarification, so that it becomes more implicit as was previously spoken to. So just wanted to echo those thoughts. Thank you.
Thank you. Mark, I see you have your hand raised.
Yeah, I was just going to say on the getting an echo here, is there something we can do about that?
Is that better? Perfect. Sorry about that. Yeah, on the point of PPE and vaccinations, I know that there's obviously very high demand at the outset of the pandemic, and large state orders that were being put in place, and healthcare facilities were priority facilities to receive PPE and vaccinations, and I don't know if it's a question of it becoming like a facility responsibility, or this is something that the state should consider in terms of like prioritizing who is eligible to receive PPE or vaccines during a situation like that. So just an alternative to consider, because I would imagine that facilities would, be challenged to determine how much PPE and vaccines they need just to cover their own care staff, but then also have to kind of like include visitors in that order as well, and how many visitors do they incorporate. So just something to think about, whether this is more of a facility issue or just like a larger state question about prioritizing which populations are in priority order to receive things like PPE and vaccines.
Thank you for that comment, Mark. Catherine, See you raise your hand.
Just echoing what Mark was saying. I think there are some elements where it really is a state policy, not an individual facility policy, vaccinations being one of them. I mean, the place we ended up in California was prioritizing for it by way of example in home support services workers. Many family members fall within that category. And I think sort of the notion of an equivalent of somebody who's providing direct support, whether that's, physical support or other kinds of support, should fall within that category. But I think particularly in a pandemic setting, that those decisions were being made by the state. They weren't being made on the county level. They weren't being made by facilities. And so I think the policy should reflect kind of the important state role in helping with kind of the PPE vaccination kinds of requirements and the ability to get that out. The only other comment I have is I will say that, and I think this came up very early, I'm sorry, I don't remember who made the comment, was that 30 days is a really long period of time for individuals who are receiving direct support. I mean, a person with dementia, such as my mother, 30 days could feel like a lifetime without having that connection, and the amount of deterioration that doesn't come back is not insignificant. So I think like I can appreciate the desire for a clear benchmark, but I don't know that I think 30 days is the right one for every circumstance.
Yeah, definitely appreciate that comment, Catherine. And maybe a clarification here that we can expand upon is 30 days was not necessarily intended here to indicate that there could be no visitation for 30 days. It was acknowledging that there could be maybe separate sets of safety protocols, but completely hear your point, and welcome other suggestions from folks on that in the chat, or if folks want to raise their hand. Karen.
So along those lines, I'd recommend 14 days. If we're going to talk about stopping visitors, 14 days max. At the beginning of a pandemic, we know how incredibly chaotic it is and nobody really knows anything. But after 14 days, we should start looking at a better protocol than just saying you got 30 days to make decisions that people won't have access to their loved ones. I'd almost go 7 days, but that gets hard to do in a, even a flu outbreak. The other thing is the last bullet point about PPE. I know that's just an example, but we need to make sure we're clarifying who decides it's a restricted access. We had some facilities throughout the pandemic and even today that had lots of PPE, maybe not the beginning, but as time went on. And we had others that didn't have a lot of PPE. And a facility can make their own PPE challenge or just access issues. So I think we need to clarify the restricted access to PPE needs to be determined by someone other than individual facilities. It needs to be a statewide restriction, not an individual area.
Tracking that. Thank you, Karen. We have one last comment from Maitli, and then we'll pause, summarize the feedback, and get a gauge of whether folks feel comfortable to move on based on the feedback shared to date. Maitli.
Hi, I just want to quickly weigh in on the time period.
Please.
Just put it out there. So if someone doesn't eat or drink for 2 or 3 days, that's probably 2 or 3 days too many, right? So I'd like like I said earlier, a person-centered approach to this, knowing the person's needs and also the facility, during an emergency is going to already be strapped for support. So I'm just putting it out there that even a week is too long for some people. Thank you.
Thank you. Yeah, completely tracking that. Nancy?
Hi, thanks, Juliet. Maitli, thank you. Sorry, I'm unable to be on video because of the skin condition. I can't put anything on it. So I just wanted to say thanks, Maitli. I was just about to say something very, very similar, almost like a challenge to anyone who thinks that 14 days or 30 days would be feasible or allowable to go that length of time without eating or drinking or bathing or toileting, and see if it's doable, you know, because it's really not. It's really not. Any bit of nourishment that one person can get might be life-saving for them on any given day. So that's all. And I'd like to see the word essential in there somewhere. I put that in the chat. Thanks for letting me talk.
Thank you so much for sharing, Nancy. Mark, I see you have your hand raised.
Yeah, just one.
Possible suggestion, which would be to maybe for our public health colleagues to talk about how resources like PPE and vaccines do go through a prioritization protocol or system. I know that there's federal recommendations that are made by groups of health experts, and then there's this, I believe, a state committee. So I think what we're really talking about here is possibly prioritizing visitors as a priority population. And so it might be helpful just for folks to see that process. And maybe that's something public health can provide to us, and then we can then do some website.
Mark, I'm not sure if you were referring to CDPH public health or local public health. I see that Chelsea and I are both on today. We're not in that kind of process flow of prioritization for things like PPE or vaccination. So can't really speak to that process. But perhaps we could get somebody that could weigh in on that in a future conversation, or just via email or something.
A big recollections from the beginning of the pandemic that you had federal recommendations about priority populations, and then there was like a flow that went into states, and then states came up with their own sort of like.
Yeah, but totally outside of Center for Healthcare Quality, and I would hate to misrepresent what their process was.
You also been CDPH, or if one of our local public health experts has that process. But yeah.
Yeah, this is Anissa Davis, the city health officer for the city of Long Beach. Here we are. Thank you. I was trying to figure out how to start my video. And so I think just to kind of go over what I remember of the process, I think it was really hampered by the fact that there was such low amounts of PPE. So I think that made things very like maybe not standard. Like I think we have the usual way that we would do things if you had a supply, and then there was the way that this ended up going because there were such big gaps and what was needed, like having needed to be tested for N95s versus just needing some surgical masks. So there was just a lot of things that went into this particular event. But in general, so when there's scarcity, in general for things, it does start with the feds. So they, especially if they're the ones that are supplying. And I think that was kind of an issue too, because there was a federal stockpile, then we had some state stockpiles, we had some local stockpiles. And then a lot of people were doing things on the private market and trying to buy. And that was complicated because we were trying to have the feds buy everything. And if you remember that they weren't doing that at the beginning. And so then you had all the states competing against each other. So I feel like, we could definitely get kind of what the process is, but I feel like there are so many different variables in this particular activation that I don't know how much it would inform what we would do for the next one, if that makes any sense.
I would agree with Anissa. I think just overall speaking to our experience with COVID, it was so atypical of any other kind of situation that we've dealt with. I think we would need to exercise caution to kind of use that as a model, but certainly as a point of reference in the context of visitation. If per your recommendation, Mark, we explore kind of how that rolled out, but is certainly a unique experience in this case because it was so widespread.
And I would just want that to be acknowledged before we put forward recommendations. I mean, I'd hate to put a time frame in statute that feasibly could not be met. So I think there must be parameters that as soon as sufficient PPE or vaccines become available, because I do remember that, particularly with the vaccination process. Once you had certain quantities of vaccines available, there were priority populations kind of like in an order that were eligible to receive the vaccine at different points in time.
Thank you for that discussion. I think one of the ways we might be able to move forward on that piece is I think we're hearing from the group, and I'm just going to start summarizing the feedback on this recommendation here. Hearing from the group that we need to add into this some kind of recommendation around state level investment, prioritization, policy relating to getting supplies and having supplies be available to visitors. So I think maybe the suggestion would be, we'll take that back and we'll workshop something and then circulate it back to the work group for additional workshopping and feedback and iteration. But that's one big one that we're hearing, that state recommendation or state level, not facility level recommendation around supplies that enable safety protocols and that would enable visitors to do the same and follow the same safety protocols as staff. I'm also hearing some concern with the language in the examples, and I think one thing we can do is we can just take out the examples, like those were intended for illustration for this group, but that's certainly a way we can adjust that. And then a lot of feedback around 30 days. So we're hearing a couple different elements around 30 days. Either setting a different number or defining that significantly differently in terms of what it means for the situation to persist. And then also hearing from a number of folks, in particular situations of distress and crisis, if someone's not eating, someone's not sleeping, someone's not drinking, acknowledging that you can't just lock down visitation in those situations. And perhaps we can explore that a little bit more and add some definition in the compassionate care section that might help us with that element as well. So those are the big elements of feedback that I'm hearing. And really great conversation. Thank you, everyone. With that, if we could go to the next slide, and I have my eye on the chat. It's very active. It's a little hard to do both the verbal and the chat, so we will go through it again afterwards. But if I missed anything, please indicate that. So as we did in the last one, we're going to ask everyone to just tell us how they're feeling about where we're landing. Again, this is not a vote. This is not an affirmation that exactly what was on that slide is what we want to move forward with. It's really indicating a level of support for the combination of the straw model recommendation and the areas we just discussed to workshop. So acknowledging that we'll do that workshopping. Are folks comfortable with moving on? Do they have agreement? Is there anyone that would like us to actually stop and keep discussing this before we move on to the next one because they feel we have not captured critical feedback on this recommendation? Moving to the next slide, we'll start to take a look at how folks are feeling. Seeing some general comfort with the direction of this, the feedback we've gotten to date, and that we can move into the next section. All right. With that, we'll just take a moment to see if there's anyone who's joined us from the public today who would like to add any comments on this particular recommendation. And I see, Teresa, you've raised your hand.
Yeah, 30, if you're really going to treat especially essential resident designated support people the same as staff, you need to do that, period. And I would just get rid of any exceptions. This is why people died. And the nursing home staff did not admit their shortcomings, did not notice that people were dying. And this is too dangerous. To make any exceptions is too dangerous. Thank you.
Thank you for your comments, Teresa. Karen, I see you've raised your hand. Let me allow you to unmute yourself. You should be able to unmute yourself.
I guess I just wanted to say, obviously, I think everybody here understands how necessary this is to have to try to get a bill that might be able to go through, or to put some principles that would be able to be passed here in California. I just want to reiterate how important it was, because I did go through a process last year for myself to, since there was a term essential support person or essential care person in, you know, in like the California Department of Health and in Los Angeles, there was a term, but they didn't have a process. There was no process to go through. So I went out to the California Department of Health, the LA Department of Health. My mom's in an assisted living, so I went to the Department of Social Services. I went to the ombudsman. I went to the state ombudsman. I went to all sorts of people to go to find out, how do I become an essential support person? How do I become a designated person? My mother is deteriorating. I can't get in to see her. She's, you know, she's losing weight. She's depressed. She's this. And there was no process. Everybody said, sorry, that's not my job. You know, we don't have a process for this. So I just want to point out how important this is, because there was no process. And finally, I found a person at the LA County Department of Health, a medical director, that said, you know, I'm deciding that you should be one because your mother has a cognitive impairment, and you are the designated support person. And she wrote me a letter, and I was able to go in. So the point is I think a person should be a designated support person if, you know, if I say so or my mother says so, and that should be the main definition. And I found someone that was, you know, that had the guts to say that should be the case. It was clear that my mother needed someone because she was, you know, she was failing because she didn't have the support she needed. And I was able to go right in at that time. You know, and yes, I did take risk, and yes, I did get COVID, but I was willing to take the risk. It was informed consent on my part. And I think people should be able to make that decision.
Thank you, Karen, for your comments. All right, I think that leads us into our next section. So this is now workshop, and as you can see, this is complicated because the font size has gotten much smaller. This is now workshopping a recommendation about parameters beyond safety protocols like vaccination, PPE, et cetera, that we just talked about, that may exist around visitation during a state of emergency. So again, want to kind of reframe for people that this came from this principle that the work group provided feedback on, that the work group did not want to leave it to individual long-term care facilities to determine what the standards should be in their facility, because we'd see a lot of variation in what the standards were. And so here we've put together a straw model recommendation based on some of what we've heard from the work group to date around what some standards might look like. So I'll just go through these, and then same as we did last time, we'll take comments. So the high level framing here is that as a standard during a state of emergency, the work group recommends that visiting parameters must reasonably allow, we'll talk about what that means, resident designated visitors to conduct in-person visits with the resident, and must at least meet minimum standards on the number of permitted simultaneous visitors, visiting hours, and locations of visitation. So I will say this is a kind of a two-part recommendation, and it's important because those go together. So the first principle, and it's the overarching principle across all of this, is that to reasonably allow visitation, parameters must account for, and we welcome additional elements to include here, the mobility, accessibility, translation needs, employment hours, travel, and other reasonable determinants of visitation for individual resident and visitor. So this is, I think we heard a few comments about this being a person-centered approach. This is kind of a draft statement that reflects that concept. that says, the hours of visitation that work for one person may not be the same as the ones that work for another. And we need to acknowledge that in the recommendation. So that's that first element and that first component of the rule. Then we note subject to the condition above. So subject to reasonably allowing visitation based on individual parameters to visitation. Long-term care facilities may establish visiting parameters due to a reasonable public health or safety risk as follows. So here we've outlined a preliminary set for this work group to workshop, a preliminary set of minimum parameters relating to all of the core things we've been talking about, and welcome iteration, additions from the work group on this. So the first is that long-term care facilities may limit simultaneous resident designated visitors due to a reasonable public health or safety risk, but must allow it at least one at any given time. So that's one. Two, long-term care visitors may limit visits to specific locations within the facility, but those locations must reasonably allow visitation as defined above. So this is in part intended to acknowledge some of the feedback we heard in earlier sessions that, for example, you could, in a situation where two residents share a room, if one isn't mobile, requiring them to be in a different location for visitation in that particular scenario may not be feasible. So acknowledging that. And then the third piece here, long-term care facilities may limit the hours of visitation, but those hours must include weekend and evening options and must reasonably allow visitation as defined above. Finally, we note that all facilities must post their visitation policies on their website in a manner that is accessible for resident and resident designated visitors. Policies must include details on any parameters to visitation, and policies must be up to date. With that, I'm going to invite folks to provide feedback on any of these proposed parameters or approaches to setting visitation parameters. And Nancy, you have your hand raised.
Hi, can you hear me okay?
Yep, we can hear you.
Okay. Sorry, I was asked to start my video, but unfortunately I can't be on camera. So sorry about that. So for the first bullet point where it says long-term care facility may limit simultaneous resident designated visitors, but must allow at least one at any given time, can we specify at least one per resident?
Yes, thank you for that comment.
Okay.
Ellen, I see you've raised your hand.
Yes, the comment I have is that whatever limitations are being imposed by the facility have to tie back to the emergency so that it will impact facilities within a certain grouping, and there's a reason for it. And I'll just use the pandemic as an example. When there was an active outbreak that brought risk to residents and visitors, the visitation policy was changed and there was guidance on how to make that happen. So I think it just goes back to the comment. It can't be a location specific. It has to tie back to the conditions at large.
Thank you for that comment, Ellen. Melody, I see you've raised your hand.
And on the third item, the hours of visitation, I see that it must include weekend and evening options, and that's helpful. The language I feel should be changed to options 24 hours. At points, there are situations where maybe a family member works, they've just done a double shift themselves and they're not getting out until 11 o'clock. And I know it's probably not usual time that a visit would take place, but that needs to be open. And so many times visitation was subjective, to the facility. For example, the facility where my chosen family are and my husband was, even for window visits, the parameters were set at there were 3 slots during the week between 11 and 2 p.m. They would only schedule 2 residents to have visitors during that time. And you could only have 1 visit per month. And that was subject to the availability of the activities director schedule. And so that meant, if you do the math in a 99-bed facility, not everyone could even get a visit during that month. So just that we're not, that we're allowing the facility to make some decisions based on what some of their needs are. We want to be, open to that, but at the same time, to recognize that the priority is that connection with the family and the resident designated support persons. Thank you.
Thank you, Melody. Eric, I see you have your hand raised.
Yeah, I'd suggest that this language is really problematic in a few areas. The basic problem is that this may be an area where we don't want it to be resident centered. There should be rights, right? The people should be able to visit. And to the extent that we start talking about reasonable and resident centered and based on needs, those are opportunities for a facility to say, well, under this situation, all that's required is this, that, or the other thing. So I would recommend rethinking a focus on flexibility, because flexibility, if we were running facilities, maybe that would be a great thing. But in practice, flexibility to the facility operator is that they're going to do things in a way that may not be beneficial to residents and visitors. So I think, I think that language through this particular slide is problematic. And then an example of this, just a specific example, the evening and weekend hours, it suggested it's a good thing that people would be able to maybe have a couple hours on the weekends. Of course, just what the previous commenter said, it should be, around the clock or as accessible as is possible, whatever that is. Under the basic nursing facility standards, generally, you do have a right to visit, or a resident has a right to accept visitors at any hour of the day or night. So the way it's written right now, reading between the lines, it suggests that, well, maybe if the facility will do you a favor, they'll give you a couple hours on Saturdays and Sundays. And that's when people are most likely to visit. It may be less convenient for the staff, there may be lesser staff, but that's when adult children and grandchildren and neighbors and whatnot are off of work and are more able to visit. So that's my impression, first take on looking through this. I think it's would give way too much leeway to a facility to turn this in ways that would be unhelpful.
Thank you for that comment, Eric. I do just have a follow-up for you, if you don't mind. So I think you kind of spoke to the balance between flexibility and kind of setting a standard and saying this is what it needs to be. I think what we're trying to thread the needle on here, and would love your kind of thoughts, maybe not necessarily right now on the spot, but would love kind of the thoughts on how, whether this concept of setting a baseline, but then acknowledging the baseline may actually not be enough for all people. And so for certain people, you may need to go above the baseline. That's kind of the intent here. I'm wondering how that resonates for you, or if that general approach is kind of where you see the problem.
I would think that, again, we're not looking at specific language, but a framework that had some solid guarantees to begin with, but offered the option to expand that in certain circumstances as necessary for particular needs, that would be a positive thing.
Okay. So it's maybe the kind of feedback here is about strengthening what those baseline requirements are. So not saying must include weekend and evening options, but actually being much more directive about and expansive on what that looks like.
Yeah,
that baseline looks like.
Yeah, I think you need a baseline here, because there's not much of a baseline here. If you looked at this and said, okay, what does the facility absolutely positively have to offer? I don't think there's much here that's solid from that.
Okay. Tracking. Thank you, Eric. Catherine, you're next on the line.
I get, this goes back to the way earlier comment that Tony and others made is, who are we talking about here, right? So facilities have policies currently, and there's regulations about visitors. So is this the assumption that those visitation policies have been suspended and now we're carving out a different group of people, which is really then not visitors, right? Not all visitors. So I feel like that fundamental question that was asked about sort of who are we talking about and who should we call them is in part why this is getting more challenging as we go through it, because it seems like we're not really talking about visitors, that there's sort of this underlying assumption that in a state of emergency, visitation is not happening, but there's now going to be a carve out for resident designated visitors that's different than regular visitation. And I think it's when you say they have to post their policies, visitation policies, well, is that different than what they currently allow for visitors? Or it's just, I think it's getting very muddled at this point, honestly.
Okay, that's helpful, Catherine. I think maybe like a first blush response to that, and then we'll keep going in the line to hear what other folks think. The intent here was to start to capture a recommendation for specifically resident designated visitors. So I'm acknowledging I think we've sort of acknowledged we're setting aside and putting ombudsmen, state surveyors, healthcare providers into kind of a different category, although welcome thoughts if people disagree with that, but that's kind of where I was operating on from here. And the idea here is to say, in a state of emergency, if a facility is saying that there need to be some limitations to visitation related to a reasonable public health or safety risk caused by the state of emergency, this is what it at least has to look like to enable visitation. That's kind of the general concept, but certainly welcome refinements or additional questions or ways we can make that more clear.
So maybe it's just being clear throughout, like it says, as a standard during a state of emergency. Well, it's not just a state of emergency, it's a state of emergency in which there are restrictions, right? So to link those two more specifically. And I mean, sort of a conundrum I faced during the pandemic was people providing other kinds of care could go in. So a physician or a nurse or a hospice person could go in, but I was a relative visitor and I couldn't. So I'm not sure making a distinction about between those groups that you mentioned makes particular sense. If like, so you're limiting general visitation, but why would a nurse have a different set of rights? A nurse is providing a certain kind of care, but in this case, these are family members or designated people in the broadest sense that are also providing care. So I agree with separating them, but I'm not sure it makes the right to being at the facility, providing that support any different between them, right?
Okay, yep, tracking that.
Thank you.
Thank you, Catherine. Karen.
Hi, I kind of want to reiterate, I think the word reasonably kind of messes up the policy. The facility must allow resident designated visitation or whatever we're calling it. But when you add the word reasonable, it starts to change what my definition of reasonable is compared to somebody else's definition of reasonable. And I think it just must allow. There really can't be any reasonable test to that. And I would say that throughout this section. And one of my kind of personal pet peeves is the second bullet point there on limiting where the visitation can occur. And I know you kind of quoted what I had mentioned in a previous meeting that, when you've got a resident who is fairly bedbound or mostly bedbound or fully bedbound, and they have a roommate who may or may not leave the room, this still leaves that person kind of high and dry with visits. So we need to beef up that second bullet point that, the visit has to be allowed in the resident's room when that resident cannot or will not be able to leave their room. It's got to be stronger language, or we're going to continue to have people who can't leave their room in a reasonable manner, especially during, with COVID. We saw people, they didn't have the staff to get people up regularly, and then to ask them to do that for a visit, they were the least likely to get an access to a visitor appointment because it was so hard to get them out of their room. So we need to have those visits allowed in their room, even during the pandemic of some kind. The PPE will protect them in a giant visiting room. It'll certainly protect them in a bedroom or a facility room.
Thank you, Karen. I'm hearing a couple things there. There's this challenge around the reasonably, and maybe having that actually be more of something that reflects a person-centeredness and reframing that language, maybe based on what we're hearing. And perhaps on that second criteria around location, having a very specific parameter around shared rooms specifically. Great. Thank you.
Well, shared room, or where the person can't leave the room, because part of the challenge was these designated visitor areas were kind of near the front of the facility, and they didn't want wandering the building.
Yeah.
And so that caused its own trouble.
Thank you. DM, I see you've raised your hand.
Thank you. Just to comment from the facility side, when we're looking at all of these different requirements on the facility, I do just want to say that it has to be feasible for a facility in an emergency to actually be able to implement. And so having giant lists of who could be a designated visitor, or having changing things that must be put on a website, or not allowing certain changes, we just have to be cognizant that a facility will be in an emergency, and we do have to think about their ability to follow all of these things which allow visitors to be in the facility. And it can get very difficult because they are getting all of the recommendations and requirements from multiple different outside places, and then they have to follow the most strict of those, and then we're going to have a separate thing. And so I'd love to have something that's really easy for all the facilities to follow, but it also can't be labor intensive, because the reason that so many things were limited with visitors during the pandemic was because there wasn't enough staff to have people watching. And that was one of the requirements, was that we had to observe some of these interactions. And I can tell you, facility staff don't necessarily want to be observing interactions, but it was one of those requirements. So, I just want to throw that out there, that we do need to be understanding. And when we say we want to be person-centered, the only issue being there is that we also have to be equitable. And so if I make reasonable accommodation for what's happening with this one family, I need to understand I'm going to have to probably do the same thing for another. And then again, we come into that, how do I feasibly make that happen for everybody when I have 99 residents and they all have different wants and needs? And you can try, but in an emergency, there is some limitations to the things that we can do. And a lot of these restrictions were initially imposed by outside forces, and it wasn't necessarily what the facility was used to doing or wanting to doing. We've always had all week and all weekend visiting. We did limit overnight unless there were special circumstances, just because we have to still keep the residents safe and be aware of who's in the facility. So, facilities need to have something they can reasonably follow, but we have to understand it has to be feasible in an emergency for them to follow it. So thank you for your time.
Thank you for that. Really appreciate you lifting up those considerations as well. Nancy, let's see, you've raised your hand.
Hi, thanks for letting me speak again. I'm not sure about the reasonably allow, like who's the voice of reason, I guess. Because so my facility, for instance, just in my own experience, I had had some help from Tony Chicatel when my facility was putting up signs saying that there was only 6 hours of visitation per day allowed to the public. And that was a sign up on the door. There were several signs up on the front door, actually, that all stated the same thing. But in small print, it said, unless you've been given previous permission. And I hadn't seen my mom in 3 years, and she wanted to come out, and I was not given permission to see her outside of those hours because I had contacted and filed a grievance with CDPH and through my insurance company, and contacted the ombudsman. And I was also assisting other residents with getting the ombudsman's phone number, which was really frowned upon. And so I was not given permission by the person who was the voice of reason to have a visit. It was actually in the evening, but after the administrator's visiting designated visiting hours. That's all.
Thank you. Thank you for your comment. I have my eye on the time, so I'm just going to keep moving through the list, but thank you. Sally, you have your hand raised.
Thank you. Just a couple of comments. I think piggybacking on what Deanne said, specifically looking at the website requirement, I think that's an example of something that might be too specific. In an emergency and you've got all hands on deck, keeping a website updated may not be the best use of people's time. So I think there might be another way to look at that. There's certainly active communication processes with both residents and family members that perhaps might be more efficient. And then the other thing is more of a question. I wonder, as we've talked through these protocols previously, if there was any discussion around what would happen if there were an active outbreak of COVID, if we're using that as an example, how would that impact these protocols?
Thank you for that comment, Sally. I'm going to go to Mark.
Great. Why don't we do Tony and Jason first, and I'll go last.
Okay, great. Tony.
Yeah, hi. I think this is the first place in the principles or recommendations where we talk about a facility having a specific visitation policy that might be different from another facilities. And I want to be a little bit careful there because I think a lot of part of our principles are to avoid variation between the facilities. And I can certainly see situations where a facility's policies would be different from another. Like this is the number you call to let us know you're coming, or this is the person you report to when you get here. This is the room that you go to. So there's going to be some variation there, but I would suggest adding another bullet point here. You have, policies must include, policies must be. I would include something like policies must provide the legally required access, or policies must avoid any impermissible, illegal restrictions on visitation. Something that says we're all starting from the same point based on your county or the state guidance, and then you've got your own, idiosyncratic things that that don't infringe on those state, county, federal standards.
Great, thank you, Tony. Jason.
Hey, yeah, just to piggyback and add to what a couple of other people here said in the comments and on video, I think a good way of framing this is to say the least restrictive, parameters allowable under state, local, and federal law. I saw a comment in the chat about, well, that's confusing because, the federal law trumps the state law, for example. But I mean, I think it fundamentally does make sense because whatever the least restrictive, most authoritative, law applies, I think that would set the baseline. And I think it is coming at it from a completely different perspective, kind of to Tony's point, where we're looking at it from the perspective of a resident's right. It's a right for them to have visitors. So anything that would limit that right in any way should be justifiable. And I want to make sure that, like, I do think that it gets away from some of the problem that could be created by allowing, by the word reasonably, and people differing on what's reasonable, because it's really more objective to say like the least because we have to also acknowledge on the facility side, like facilities could be designed differently. The space itself could be designed in a way that it makes it difficult for people to interact in a certain space. And so I think really just making it coming at it from that opposite perspective would help.
Thank you for that comment. I will go to Mark next.
Yeah, and what I was really going to suggest, that some of these points that Tony, Jason, and Eric made earlier about, the language and the paradigm maybe not being quite right, or maybe there needs to be a stronger, more specifically established baseline. We would love to get language, that would really help, because we can come up with things, but really if you have something very specific in mind, like language that you find suitable, I think it's important to put in there. The only other sort of option I'm entertaining, and I don't want this to be overly bureaucratic, because of course in times of emergency, time's vital, but it does strike me that every emergency is going to be different. I mean, the COVID pandemic was one thing. There will be future pandemics. There will be other emergencies that we can't contemplate because we haven't experienced them. But it may be necessary to adopt different baselines for different situations. And we contemplate things like work groups of public health officials and facility operators and advocates and family members. Possibly that's something that you could contemplate here, is convening such a work group to establish baseline standards in times of emergency. So just another thought, but really any language, any additional thoughts would be very welcome in this space. But I really think this is the crux, and that's why I'm so glad Deanne spoke up from a facilities perspective, because this is where we really have to hear from facilities and public health about what they think would work or what concerns that they have, so that we can start getting to some good middle ground or opportunities there.
Thank you for those comments, Mark. I'm going to take a stab at summarizing this feedback. I took many pages of notes I've been taking notes the whole time, so I'm going to try, and I may miss some things from this one. I think the biggest, there's really a few big ones. A lot of concern with the term reasonably allow, heard that loud and clear. And so I think what we'll do, what we endeavored, kind of the spirit of that was getting to the person-centeredness that has been raised in a few different places. And so we'll revise the language there and take a new pass at that to see how it lands. The intent there is really to emphasize that a one-size-fits-all approach may not work all of the time. At the same time, we want to set a standard. So I do invite, we are going to move on in terms of public comments, or in terms of verbal comments, but if folks generally don't think that framework of having, here is the minimum, here's what you have to do, but then acknowledging some person-centeredness that may require facilities to go beyond that in certain scenarios, if anyone feels that that general framework isn't landing right for them, really invite you to drop that in the chat. Because we'd love to look at that and iterate on it and make sure we're really hearing everyone's perspective on that general approach of saying this is the baseline, it has to be for every facility, and then there's going to be some person-centeredness we need to consider around things like language, translation, accessibility, mobility, et cetera. So that's one thing that I'm hearing. The second I'm hearing is to strengthen some of these standards. And so there, again, really going to ask folks if they can drop in the chat for some of these standards. I think I heard a lot of feedback around specifically that third one around hours of visitation. Really welcome people to drop in the chat what they would recommend setting as the standard there, as the baseline. And we'll review that and iterate on it and pull together something additional. Also hearing, just kind of moving through, in this last one around policies, that the posting on the website may not be exactly the right approach there. We want to ensure there's transparency, and so let's look at exactly what the right way to frame that is. That last requirement, and being clear there. And then I'll also note just a global comment. I think that applies to this one and other ones. It's to be much more clear about what we mean by during a standard during a state of emergency, that we are talking about a state of emergency in which a reasonable public health or safety standard related to that emergency may impact visitation in any way. That was my attempt to summarize our conversation. If I missed anything, really, please invite folks to drop that in the chat. I don't know that it makes sense for us to vote on this one because I think we have enough things to iterate on that I'm sure folks are not quite comfortable voting yet. Or sorry, I don't mean voting. This is not a vote, as I said. Not quite comfortable kind of giving an indication of support. I will just kind of open one last time to see if there are any additional points of feedback, because as Mark noted, this is kind of the crux of the issue here. Any additional comments? And we'll go over, if we go to the next slide, into the public comments. And if there's any, Teresa, I see you have your hand raised. We need to go.
Yeah, I think you should throw this out and start over. This profoundly shows that someone's not getting it. Basically, it should be the clinical and ethical standard for everything else in long-term care facilities is least restrictive. Any restriction needs to be person-centered and flexible, and any restriction has to be justified. And there is no justification for limiting time of visitation or even simultaneous visitation. It's got to be. I mean, I think just throw it out and start over. Thanks.
Thank you for your comments. Karen?
Am I unmuted? Yes. So this question about most restrictive and less restrictive, I don't understand. What they use is most restrictive, and then someone said, well, we'll just use less restrictive. But who makes that decision? You can't just say that. The agencies use most restrictive. That's what they tell us when we call, or that is the rule. So you can't just throw it out. And a number of people have said that is what they use, most restrictive. And in this particular case, in say our state, which we're talking about, the local counties were usually the most restrictive, and then the state was above that, and then CMS was least restrictive. So for most of us, our facilities, particularly say in Los Angeles, it was very restrictive because of the rate of COVID. So that's the way it was for us. So you can't just say, I mean, I'd love to use the least restrictive because I was told that so many times my head would spin. So we need to figure out if that's a possibility and who makes that decision. I mean, I would love for the facility to use least restrictive because they were always telling me you have to use most restrictive. And when I went to the licensing agency, who in my case is Department of Social Services, they said to me, you have to use the most restrictive. So, I don't know who makes that decision, but that, we have to know what's being used, least restrictive or most restrictive. Thank you.
Thank you for your comments, Karen. All right, I do have my eye on the time. We have about 20 minutes left today. I think what we'll do, we're likely not going, well, we're not going, I'll just say it. We're not going to be able to cover the conversation about what it looks like in a situation that we don't anticipate, where the standards that this work group will eventually land on may not apply. So we'll kind of, I think at this stage, given we have 20 minutes left, we'll go ahead and say that that'll be kind of the core conversation of meeting 4, in addition to the appeals process, grievances and appeals process. We will ask people to provide some offline feedback on that. We're going to talk about that more in a moment, because since we only have one more meeting of this group, we are going to ask for some feedback between the meetings so that we can really land some of these pieces, just acknowledging that time is running out. So this last section that I want to cover with the group today relates to compassionate care. Oh, great. So if we could just go to the compassionate care section. Thank you. So this is around setting a recommendation for long-term care facilities to expand their efforts to enable visitation in a situation requiring, like in a compassionate care situation. And so this is one of those areas where we want to acknowledge some of the comments made earlier about like a situation where someone's not eating, a situation where someone's not drinking, and acknowledging that those are urgent situations, and weaving that into their recommendations, that acknowledgement that those are urgent and they can't wait. So here what we've taken a first pass at is stating what that might look like. So we begin by stating by an initial definition of compassionate care, and I don't think we'll fully get through a definition today, so we're going to ask for a lot of offline feedback on this one as well as invite people to put it in the chat right now. We'll note compassionate care is defined in the CMS definition as visits for a resident whose health has sharply declined or has experienced a significant change in circumstance. And so the work group can decide to put a lot more definition on that if we'd like, or we can leave that as the very broad definition of compassionate care, acknowledging, as I think many folks have noted on this work group, it's not just 1 or 2 situations. There are a number of different situations that may require compassionate care. Then we indicate here in the case of I'm losing my ability to speak. In the case of compassionate care, visiting parameters established due to a legitimate public health, safety, or operational risk must allow as many simultaneous visitors as determined by the resident and as space and safety protocols reasonably allow, and should not limit the hours of visitation. So I'm going to pause here. And I think a core piece to consider kind of as a subtext on this whole recommendation is whether the group wants to kind of provide very specific standards in a situation of compassionate care that is elevated and kind of acknowledge that in the recommendation. And I'm seeing some notes in the chat about noting it's not just a physical health decline. And some agreement around keeping the parameters broad around what constitutes compassionate care, because it's not just 1 or 2 situations. Karen, I see you've raised your hand.
So 2 things. I want to agree that it's definitely more, there's behavioral issues also. During the pandemic, a lot of facilities struggled with having staff who weren't just overwhelmed. And when residents were having behavioral challenges for whatever reason, having family come in and help made a huge difference. And when they couldn't come in, it made also a huge difference. But along that line, I think we have to be careful with the word compassionate care. It's almost like a hospice term. And some people may find it offensive to say they're giving compassionate care to a loved one, with the connotation that maybe they're, towards the end of life. So we may need to either add to it or wordsmith it a bit.
Mm-hmm. Thank you. Melody.
Yeah, I had my hand raised, but basically what Karen said, I agree on that language on compassionate care, and also the policy in and of itself is going, to include resident designated support persons at any time. So what I'm getting from what I'm seeing in the language is the compassionate care would go above and beyond that to those outside of those resident designated support persons. And, as noted, it could not be just end of life, but, critical situation that could be physical or mental, emotional health as well. But thank you, Karen. Well, very well said.
Lee, I see you've raised your hand.
Right. So my concern is that these situations, when someone's not eating enough or drinking enough, they're not necessarily being recognized and reported. And I don't want to say that the staff means to miss it. It's just they're overwhelmed in a pandemic, an emergency, whatever it is, it's going to happen again. I don't think that there is really any solution to that other than ensuring that they're not the ones we're relying on for that information. That's pretty much what I have to say about that. And also, retaliation does happen too. So that's something to consider. Lately, that's been a big topic, at a lot of the advocacy organizations. I don't know why it's suddenly being discussed. Maybe it's because it's too hard to pin down and to prove, but that's a factor to consider as well. Thank you.
Thank you for that comment. So hearing some general alignment behind the work group having a recommendation for elevated standards in a situation of crisis, and we can talk about the language of it, whether it's compassionate care or a different term, but elevated standards in a moment of crisis to really enable robust visitation to support residents. I think if there's no additional comments on this one, we can kind of move to a pulse check to see where people are and if anyone has concerns with this approach and wants to say that they're not kind of feel like that their level of support for this is not currently very high. So we'll open up that survey again and ask folks to weigh in on how they feel about this particular recommendation at this point. Let's pull the questions. And just flagging, because I'm seeing some questions about this in the chat, the survey itself is for workgroup members, although we'll invite public comment in just a moment, but the survey itself is for workgroup members, but members of the public can see the results as they're coming through right now. This particular exercise is to get a pulse check from the workgroup. Okay. Seeing some support. Okay, we've got some concern about a compassionate care recommendation. All right. I think in that situation, we can pause for a moment and just talk this through a little bit further. So if we could go back to the recommendation. So the core concept here is the concept that the work group would recommend elevated access to visitation in a situation where a state of emergency is, sorry, looking at the chat at the same time and distracting myself, in a situation where a state of emergency does have public health or safety risks directly associated with the state of emergency that may impact in any way visitation. This recommendation would state that as a minimum in a case of compassion, in a case of crisis, in a moment of crisis, facilities would allow as many visitors as the space allows and safety protocols allow, and should not limit the hours of visitation. So I'm gonna encourage folks, if there are kind of red flag areas here for people or particular phrases in this that they are very concerned with, to either kind of raise their hand and share that or drop it in the chat. Or if there's particular things that we could add to this recommendation. Karen, I see you raised your hand.
I just want to be careful with that first bullet, or the kind of the sub bullet point on the need for compassionate care visit may be identified. There was certainly a kind of a standard that started that if the resident designated visitor or any visitor sort of said, whoa, my loved one needs compassionate care visit, that held significantly less weight than if the facility staff or, you know, some public health type person identified it. So you need to make sure that the verbiage is that they have equal weight, so that the visitor doesn't get sort of just kind of ignored because they're saying, wow, my loved one's having these issues, as opposed to somebody associated with the facility.
Parking that. Thank you, Karen. Any other comments related to a compassionate care recommendation? I'm using the term compassionate care because I don't have another term for it right now, but we will think through that. We have a raised hand. I'm not able to see who it is because they're listed as long-term care facility policy workgroup panelists, but hoping they can come off mute.
Hi, this is Mercedes. I wrote on the chat. So one issue that I had already with the existing definition that's provided by the CDPH. So my brother, he's not verbal, and and most of the patients or residents in that facility are not verbal. So it's hard for me to justify, because the administrator gives me a lot of like pushback when I said, oh, we're considered, you know, compassionate visitors. And he's like, oh, well, if you're one, everybody here's one. And I'm like, yeah, what's wrong with that? So the issue I'm having is, you know, it's so hard for me to say, well, my brother, I can't say, hey, my brother said he's feeling depressed. It's so hard. Only I and my mother are better interpreters of his care, and we can read him much better. And so there's that, to me, feels like this loophole where because he doesn't eat, he has a feeding tube, you know. Maybe these things may not apply, but it doesn't mean that, you know, he didn't suffer, you know, depression and isolation and all these things that I know he did suffer. So I just kind of wanted to bring that up because I don't feel like in any of this we are considering these cases or residents with, you know, he's severely disabled. My mom are literally the people who interpret his needs. And then again, you know, the facility where he's at wouldn't consider him to be, you know, they said, oh, nothing, you know, his health is the same and everything. And we're like, it clearly isn't. So I'm not sure if that made sense to you all. But yeah, but I continue to look at this, and I continue to look at this definition of, like, you know, on the DPH guidance. And it's a little frustrating because to this day, because in order to get this title of becoming a compassionate visitor, I have to have a meeting with the administrator, the doctor, and the care plan team. And basically they refused to give me that meeting. So yeah, I'm just pointing these things out because they may seem trivial, but when it comes to the nitty-gritty, these are the things that we're trying to eliminate, you know? That's all.
Thank you. Appreciate those comments. I'm just looking at our line. We have Blanca Castro with her hand raised.
Hi, good afternoon, everyone, and thank you for excellent facilitation. I just wanted to flag two items. One is with regard to the term compassionate care and recognizing that that is troublesome for a number of reasons. One of the reasons the initial bill included essential caregiving is because that could then be more person-centered and trauma-informed. And then secondly, I wanted just to echo my colleague Mark Beckley's point that it was really good to hear from CAF. This conversation right now, this is when we really need the voices of everyone. So to whatever extent I encourage public health and my other, hearing from some of the other folks that represent not just the residents and advocates for consumers, but just as importantly, public health and facilities, because that's where we got stuck, and we want to be able to move this forward and to whatever extent possible have it be a new bill that's passed. So I just wanted to add those two. Thank you.
Thank you, Blanca. I think that brings us to the end of the core of our work group conversation today. We're going to talk about next steps in a moment, but first I'm going to turn one more time to the public comments, and I see Teresa, you have your hand raised.
I think all care should be compassionate, and I think the compassionate care is a vestige of the inappropriate limitations that were put on.
Oh, we just lost you, Teresa.
And yeah, can you hear me?
Yes.
Yeah, and I think you should scrap it. All care should be compassionate. There should be minimal limitation at a baseline, and people should get what they need in this facility, in a long-term care facility. And having this vestige of inappropriate limitations continue just shows that the task force kind of isn't getting it. And I think you need to scrap the compassionate care. There has to be robust rights for visitation. Thank you.
Thank you for your comments, Teresa. And I think with that, that wraps up our last section of public comment today. Just turning my pages here. And at this point, I want to thank everyone for your engagement throughout the conversation today. I'm going to introduce the director of the Department of Aging, Susan Demeroy, to provide a few closing comments before we close.
Thank you, Juliet and the Manat team for such fantastic work. And hello to the work group and those joining us from the public. I just wanted to join for a quick minute today to thank everyone, especially our work group members, and in particular, our residents who are part of the work group, for completing 3 meetings. It's exciting to see straw scenarios laid out after just 3 meetings to really be focused on some really concrete recommendations and moving this work forward as quickly as you are. There is a sense of urgency, and I thank you for sharing that sense of urgency. I also want to thank, of course, our legislative partners who made this possible by carrying the legislation forward, and the governor for signing the bill that brings us all together here today to talk, and will bring us together for our fourth meeting coming up. And to the members of the public who joined today and those that were part of the 2 prior meetings that have helped shape the work today, I'm very grateful to the public as well. And our team, Mark and Brandy, thank you. And Blanca Castro, thanks for your great work. I am impressed. I'm impressed to see how much progress has made in a short period of time when a group of people who share common goals, but perhaps different views, come together for the good of California. So my thanks to all of you. And back to you, Juliet.
Thank you, Susan. And I think with that, I'm going to hand it over to Brandy to close us out today.
Thank you. So we are going to talk about next steps. Prior to the next work group meeting on August 22nd, CDA intends to circulate an updated draft of principles and recommendations based on today's discussion, and that'll go out to the work group. Work group members will be invited to provide written feedback on this updated draft prior to the next meeting. All drafts and feedback provided by work group members will be posted on the CDA website. The last meeting of the Long-Term Care Facility Access Policy Work Group is scheduled for August 22nd, and that will be from 12:30 to 3:30. CDA will circulate the agenda for this work group meeting to the public at least 10 days prior to August 22nd. CDA will send materials to the work group members in advance of the meeting and will post all materials to the public on our website. Work group members are encouraged to review materials prior to the meeting and consult with individuals within your organizations as needed. Materials will be listed on the Long-Term Care Facility Access Policy Workgroup webpage, which the team will drop into the chat shortly. Thank you again for participating in this very important work and for your conversation and your discussions and your patience and your willingness to collaborate. If you have questions, please reach out to us at the email listed on our slide. And our team will also drop that in the chat now. Thanks again and have a great afternoon.